All right. So this is your second PowerPoint, but second and third lectures for the remaining of the chapter 37 in airway management, your Egan's Fundamentals of Respiratory Care book. So this section, I'm going to really go a little bit more in depth into your surgical airways like tracheostomies, laryngoscopies, things like that, and then moving or laryngectomies, moving into trauma associated with ET tubes and some airway maintenance things. Okay, so your tracheostomies are maybe performed as like a regular surgical procedure. It also is done percutaneously at the bedside. So a tracheostomy is a surgical procedure that establishes access to your trachea via like an incision in your neck. This opening in the neck is then referred to as a tracheostomy. It's best performed by a physician or a surgeon in a surgical setting after the patient's airway has already been stabilized. But these also can be like emergence procedures at the bedside as well, in case of where you don't have a patent upper airway or you have an upper airway obstruction and you need to establish an airway quickly in order to ventilate. So there's a lot of different sizings related to tracheostomy tubes. It's going to depend on the patient's age, height, weight, kind of airway anatomy. So there's kind of a timeline. So there's kind of a chart at the bottom of page 767 in your book that talks about kind of the timeline for when you want to try to perform a tracheostomy for patients. So typically, if a patient still needs like an artificial airway, like an ET tube, after like a week to 2 weeks, that's when we're going to start considering putting a trach in. So some of the benefits of a trach is because of surgically where it's placed, it's going to be below the vocal cords. So you're not going to have as much vocal cord injury. The patient's going to be a lot more comfortable. They don't need as much sedation. It still maintains access into the trachea so you can remove secretions easily. Things like that. So so after about 7 to 10 days of being intubated, you might think about doing a trach. If the patient's going to be extubated or going to have that ET tube removed within a few days, you might, just kind of let it ride out a little bit longer. But after about 21 days of being intubated, you definitely are going to be getting that surgical procedure for that airway, long-term airway. Okay, so for the procedure, when you're thinking about the advantages and disadvantages, the surgical procedure is done in patients in surgery. It's done in patients with poor landmarks. So it can also be done emergently. We tend to take patients to surgery when they're younger than 12 years of age. You can do the percutaneous procedure at the bedside in the ICU, usually just under sedation or local anesthetics. And if you do it percutaneously at the bedside, that stoma or that opening usually kind of stabilizes within 5 days of the procedure. Some of the disadvantages, if you're taking this patient to surgery for it, they have to be transferred. They're going to need general anesthesia. That stoma, that opening usually takes a little bit longer, usually 7 to 10 days to stabilize. So the disadvantages of the surgical procedure. The disadvantages of the percutaneous one is that, again, it can't be done on children less than 12. And it may be, you might run into difficulty inserting the trach due to like calcifications and things like that of those cartilaginous rings in the trachea. Okay. So when you're looking at tracheostomy parts, there's a flange. So there's this flange here, which kind of stabilizes the trach at the opening, kind of holds it in place, helps you tie trach ties to it or a holder to it to keep it stable. On this flange, you're going to have the inner and outer diameter measurements. So typically the measurements for the trach are written on this flange. You're going to have a shaft, or outer cannula that sticks out from the flange. This will have a 15 millimeter universal adapter. As I've mentioned before, this 15 millimeter universal adapter is what we use for all respiratory connections. So everything should connect up together. There can be an inner cannula that is inserted inside this and removed or changed to help keep things clean, prevent infection, or if something gets coughed up and obstructs this, all I have to do is remove this part rather than the full thing to remove that obstruction. Typically you have a cuff to the trach that needs to be inflated if we're going to use mechanical ventilation. Again, I need to have a sealed airway to create that pressure to help promote ventilation, so that cuff needs to be inflated. That cuff is attached to a pilot balloon and a pilot line that, as I fill this up, will inflate this cuff down here. And there's always like a one-way valve inside these pilot balloons to make sure that the air doesn't leak back out. Finally, we have like something called an obturator. This is kind of like the stylet that we talked about in endotracheal intubation. This obturator is placed inside the tracheostomy tube, and it has a rounded tip that's going to stick out the end. And this helps for insertion of the trach tube only. So you use this just for inserting the trach tube. Once the trach tube's inserted, you pull out the obturator just like you would pull out the stylet for endotracheal intubation. Okay, so there's a lot of different sizing for tracheostomy. So and as we go over these things in labs, you will see just a small subsection of all the different types of trachs that are out there in sizes. In your book on page 769, there is a chart that goes through, comparing sizes of a Shiley to a Portex, which adds a little fun and excitement to our lives, because why couldn't they just all be the same size? Like a size 6 Shiley should be the same size as a size 6 Portex, but unfortunately that's not always how it matches. Okay, so because these don't always equate specifically to each other, you just need to, you guys, if you have a patient that comes in with a Shiley trach and your facility only carries Portex trachs, you're going to need to look at an exchange chart to make sure you're putting in the correct size, or exchanging it for the same size to the same size. So when you look at that, you want to compare the outer diameters on the flange. Generally speaking, the Shileys are going to be a little bit larger, meaning that like a size 4 Shiley usually looks like the same outer diameter size of a size 6 like Portex. Okay, so besides brands and sizing, there's a couple different types of trach tubes out there. So there are cuffed, there are cuffless or uncuffed. So you can have a cuff or you cannot have a cuff on the trach tube. You can have a fenestrated, meaning that there's a hole on the top of the trach, or an unfenestrated. You can have an extra long, and that extra long length could be either proximal, so meaning how far it goes into the kind of the length between where it enters into the trachea and when the curve starts happening, or it can be extra long distal, meaning it's longer, the part on the bottom that sticks into the trach can be long in both places or just one of those places. There are some tracheostomy, companies that make trachs with a foam cuff that helps with patients that have existing tracheal trauma. Those are usually your kind of Bavono trachs have foam cuffs. Some other types of trachs use foam cuffs. There's trachs that have the special tight to shaft water-filled cuff that also helps with reducing airflow resistance, facilitates weaning. You have some trachs that have adjustable flanges, meaning that the flange moves for better placement and comfort for patients. And then there's even tracheostomies that are metal. So Jackson trachs are considered metal trachs. So just a couple different examples here. So this is your proximal extra long, meaning, from where it enters into the trachea to where the curve happens, this distance is very long. So somebody with a really thick neck might need a proximal extra long trach. Somebody who's extremely tall or has maybe a high tracheal malacia might need an extra long distal length. So if I have a tracheal malacia that's located right about here, I might need this extra length to get past that to make sure that that's not occluding the end of my trach tube. Again, this is an example of what a foam cuff looks like. Here's an uncuffed versus a cuffed versus an uncuffed. Water-filled, tight to seal shaft cuff. These are good to reduce the amount of airway resistance or obstruction, helps facilitate weaning. Here's your examples of your fenestrated. This can be fenestrated, meaning there's a hole in it. This one has a hole there. That one has a hole there. That helps facilitate weaning from the trach and decannulation because air can flow through that hole back up through the vocal cords. So you can use this with a cuff trach with the fenestration or an uncuffed trach with the fenestration. These are those metal Jackson trachs. You don't see these as often anymore. This is like a stainless steel trach that we used to be kind of fairly common in patients that were long-term trachs. Don't see them as much anymore. Most people have switched to the plastic ones. Adjustable flange. This is an example of a Bavono trach, meaning that I can change the depth of my trach easily by inserting more or less of this trach tube. So I have these examples of these physically in the classroom, and when we're doing labs related to this, we can play with these and we'll look through them and do stuff with them, and that'll make much more sense than it'll ever make when you're sitting here and going through the bullet points of lecturing. Okay. Okay, so laryngectomy is a little bit of a different surgical procedure that you can come across patients that have had. So in this procedure, instead of just making that surgical incision in the trachea and placing a tube inside the trachea there, with a laryngectomy, we're removing the larynx completely. So this area of your anatomy is considered your larynx. So if typically this is done in patients who have had laryngeal cancer. It can also happen if somebody's had a lot of trauma to the airway from like gunshot wounds to the neck or the face, or patients that are receiving like radiation therapy for cancer treatment. This can get really necrotic and they can decide that they need to remove it. So they surgically remove this area of the airway. And then what they're going to do is take the trachea and directly attach it to the stoma. So as you see here, now my airway, my larynx is gone, so I no longer have a direct communication with my upper airway to my lower airway. Okay, so this stoma here is going right into my trachea, right down to my lungs. My trachea no longer has access to my upper airway anymore. Okay, so there's a couple things to then, as respiratory therapists, that we need to be really aware of with laryngectomy patients. If it is a complete laryngectomy, meaning that the entire larynx is removed and now our airway is kind of attached like this, these patients are not going to be able to be manually ventilated with a mask up here. because this air, anything that you put in the nose and the mouth, isn't going down into the trachea because the trachea isn't attached to it anymore. So if you have to manually ventilate these patients, you're going to be putting the mask and the bag right over the stoma and ventilating that way. Otherwise, you can just insert an endotracheal tube into this shallowly, seal off the endotracheal tube and bag through the endotracheal tube until you get a different airway in place, like a trach in place again. So patients can end up with partial laryngectomies as well, meaning that some of the larynx is still in place, so you do have communication between the upper airway and the lower airway, and in those patients you could provide manually ventilation through the mouth. It's just important, again, to know which type of patient you're dealing with, so you know where you should be bagging the patient. So some other things with this to think about is that these patients tend to have a lot more difficulty with speech than somebody who has just a typical tracheostomy. So in a typical tracheostomy, the tracheostomy is going to be tube is going to be placed here below the vocal cords. So if I deflate the cuff or I have a fenestrated trach, air is still going to be able to go through the vocal cords and make sound, resonate sound, and the patient should be able to communicate through speech. With this, because I no longer have vocal cords, it's very difficult for these patients to talk after this procedure. But there's been a couple new devices that have been on the market. One of this is this tracheal esophageal puncture, TEP, where they put a prosthetic in the back of the trachea between the esophagus that allows airflow to exit the trachea, go through the esophagus, and then back out the mouth. Patients that have had that part of the procedure done can work with speech therapy, language therapy to learn how to use their tongue and other muscles in their airway to generate sound and speak. If they haven't had that procedure done, these are the patients, laryngectomy patients are the ones that you see with little voice box, external voice boxes where they hold them up to their chest and it senses the vibrations and makes noise for them. So that is another way that these patients can, have kind of a little bit of workaround and still be able to speak. Some other complications include infection with any surgical intervention. You can have fistulas or holes develop between the trachea and the esophagus, which can cause air leaks. You can have stenosis, narrowing of the airway around the surgical sites, leaks around these prosthetics that are put in place. These patients also can experience difficulty swallowing, eating, speaking because of these surgical alterations. Okay. So some different airway trauma that's going to be associated with tracheostomy tubes. Artificial airways don't really conform exactly to patient's anatomy. So that can put some pressure on soft tissues and result in things like ischemia, fistulas, ulcerations. These artificial airways also, as the patient's moving around and shifting around, they're going to shift around in the airway, and that can cause irritation as well. So depending on the type of the tube, damage to the patient's airways can occur anywhere from the nose down to the lower trachea, okay? Tracheostomy tubes aren't going to pass through the larynx structure. So like if you're using a tracheostomy tube, that means usually the airway trauma or irritation or issues are going to be below the larynx and just kind of localized to the trachea. But laryngeal dysfunction may be kind of a secondary issue because of lack of airflow and stimulation. Okay, so your larynx and your vocal cords are used to air going through them and used to being expected to open and close. And if they kind of lose their job because they have a trach tube in place, that can cause some injury to those as well. Okay. So typically, we sometimes don't always realize that injury has happened until we take the artificial airway out, meaning that when we take the tracheostomy tube out or the endotracheal tube out, that's when we identify that there was an injury there. So typically some techniques that we use to diagnose like that airway damage could be like just doing a physical exam, maybe a bronchoscopy, a laryngoscopy. So when we're looking down into the airway, your book also mentions like air tomography, fluoroscopy, MRIs. Those are all different ways, like radiologically or with imaging, that we can look at the airway and see if there's any alterations or abnormalities. And then finally, we can look for abnormalities by looking at pulmonary function testing. Pulmonary function testing is a tool we use in respiratory therapists. Respiratory therapy is the one that usually performs these procedures. And we do a procedure called a spirometry test or a flow volume loop to look at obstructions both in the upper and lower airways of our patients. So pulmonary function testing is another great way of being able to see if there's been any trauma to the airways and new obstructions that have happened. So laryngeal lesions, so kind of the most common injuries that you're going to have to the larynx are going to be things like glottic edema. So edema and vocal cord inflammation are going to be usually resulting from like pressure from the ET tube or trauma during that intubation procedure. You can also have laryngeal or vocal cord ulcerations. Um, so uh, and then you can have vocal cord paralysis and granulomas developing. Okay, so oops. Okay, so again, I jumped ahead of myself. These are the diagnosing airway damages. These are the different procedures that you can do. Laryngeal lesions, your glottic edema, vocal cord inflammation. These are all the different things that can happen in your larynx from intubation. So the laryngeal glottic edema, vocal cord inflammation, again, that's going to be the result of pressure from that ET tube or trauma during intubation. Swelling is going to get worse over 24 hours. So after I take the tube out, little swelling might be there, but as that airway's been out, it can worsen. So this is something that we want to stay on top of. If we suspect this, we want to monitor these patients pretty carefully. Typically that hoarseness and stridor are going to be the primary symptoms, meaning that's going to be kind of our quick way of identifying this. We can treat this post-extubation by giving the patient racemic epinephrine. Again, racemic epinephrine is a vasoconstrictor, so it's going to help reduce swelling by constricting the blood flow to that site. We can give steroids like Decadron is a big one that we use a lot for glottic edema. We could do IV steroids, diuretics, cool aerosols are all different ways that we can treat glottic or airway edema. Okay. So there we go. With vocal cord paralysis, this is also likely in extubated patients if they have hoarseness and stridor. It's not going to resolve with treatment or time though. So whereas like your glottic edema, swelling, that's going to kind of resolve over time. Vocal cord paralysis typically doesn't. Sometimes the symptoms are going to resolve within 24 hours, and their full movement can kind of return within several days. But if these symptoms do keep continuing, you're going to want to get a tracheostomy too. Okay. Okay, so tracheal lesions are also kind of associated with tracheal tubes. So granulomas, tracheal malacia, tracheal stenosis, tracheal esophageal, and arterial fistulas are all different traumas that can happen in the trachea. So uh, tracheal malacia is kind of that softening of the cartilaginous rings that causes that collapse of the trachea during inspiration and expiration. Let's see if I can play. No problems with videos. I think there's a good one in your CP Phys book that shows tracheal malacia, but I will post a video separately due to the fact that this one isn't working in the lecture. Tracheal stenosis is a narrowing of the lumen of the trachea. So this is caused like scarring. It most oftenly is going to occur at that cuff side of the ET tube. So this is why we want to make sure we're maintaining or watching our cuff pressures. So here you're seeing a pretty wide open trachea, not much of an obstruction here, slight obstruction, but not too much. Here, you're noticing that this obstruction is getting worse. I'm seeing about 50 to 71% obstruction in this airway. Here, level 3, you see how this trachea is very, very narrowed at this point, almost completely obstructed. And in this picture, you see 100% obstruction, okay? So you can have different degrees of tracheal obstruction, and obviously the higher the degree of obstruction from the stenosis, the more difficulty your patient's going to have with breathing. So typically for this, they'll put like tracheal stents in to try to keep things open. So this stenosis or this narrowing doesn't affect the patency of the airway. In tracheostomy patients, like I said, most oftenly you're going to see this at the cuff site, but it can also occur at the tip of the tracheostomy tube as it's rubbing potentially against that tracheal wall. That can cause stenosis or scarring. It can also happen at the stoma site, so where that surgical incision is. Okay, so these tracheoesophageal and tracheonomic artery fistulas. This is where you end up, a fistula means that it's kind of a hole. So this is a direct communication between the trachea and the esophagus. So typically this is going to be caused by things like incorrect surgical techniques, sepsis, so infection at the site, malnutrition, which has caused difficulty with wound healing, tracheal erosion from the cuff and the tube. Again, the tip of the tube, if it's rubbing on the tracheal wall, that can cause a fistula. Esophageal erosion can also happen. So the fistula can start on the esophageal side from that NG tube as well. Okay. So these tracheal esophageal fistulas, usually that diagnosis is going to be made from like history of like a lot of aspiration. So if the patient's aspirating a lot, you can assume that there's some hole or direct communication between the trachea and the esophagus. Or if you're noticing a lot of abdominal distension because air is going from the trachea into the esophagus and down into the stomach. Otherwise, they'll usually do like an endoscopy where they'll go down with a scope and look for a hole. So treatment usually includes like a surgical closure of the defect. With the fistulas, the tracheal arterial fistula, this is when your trachea, there's an artery that runs right along your trachea and that tissue erodes between the two. This is going to be a big deal. So this will result in a massive hemorrhage if this happens. Most cases, these patients die because they're going to bleed to death really quickly. This is a very rare complication, okay? It's usually, again, from difficulty with the surgical site. So if the stoma's placed too low and there's a lot of movement in the tube, this can occur. But it's very, very rare. But if it happens, you will know it's happening because it will be a lot of blood, and there's really not much you can do to stop it. Okay. So treatment of these types of things, you can depends on the severity, and where the damage is. So they can do laser therapy to try to treat small lesions. They can do resections where they can take parts of it out. So they kind of shorten things up, take parts of it out, the damaged part out. They might do different repairs or stents for more kind of involved damage. Okay. So again, this is kind of a picture of the different ways tracheoesophageal fistulas can form. So these ones here, these type A and B, these are like congenital fistulas. So these happen as babies develop, and these types of weird fistulas happen where your esophagus didn't form correctly. When you're talking about, and C as well. Actually, A, B, C, and D are all congenital ones. E is where this is happening by like a hole that's kind of been worn through. So here's your esophagus here, here's your trachea. There's that direct communication that's happening between the two of them. Again, you're going to see that aspiration, abdominal distension with this. And it's caused by incorrect surgical techniques, sepsis, malnutrition. And here is your tracheoarterial artery fistula. I don't know how to say that. This is that erosion of the trachea with the artery that surrounds it. Typically, it's because of the stoma positioning. If this happens to you, again, very rare occurrence, you can try to hyperinflate the cuff to try to use the cuff to kind of hold pressure to that and slow the bleeding, and get the patient in for surgical intervention as quickly as possible. But these patients rarely survive because they bleed out so quickly. This artery is fairly close to your central cardiovascular system. There's a lot of blood that goes through there. So if that gets compromised, patients bleed out fairly fast. So how do we prevent these two things? We want to try to avoid a lot of tube movement because that's the primary cause of injury. So you want to use sedation where appropriate. You don't want your patient super agitated and moving this around a lot, or God forbid, self-extubating themselves. That's a big deal. You don't want them pulling their own tubes out. Remember that those nasotracheal tubes, so nasal intubations, are a little bit easier to stabilize. You can use swivel adapters when you're using a trach tube. We'll show you these in lab to reduce like movement of the tube and traction. You want to make sure that you're always selecting the correct size airway to make sure that there's no rubbing along that tracheal wall, and maintain the correct pressures in your cuffs of 20 to 30 centimeters of water pressure to reduce any injury. And then always good trach care to reduce the amount of infection risk. Okay. All right. So moving on into airway maintenance. So your role in airway maintenance is to secure the tube, maintain the tube, depending on no matter what type of tube it is, help the patient with communication aids, ensure adequate humidification. Again, anytime I bypass the upper airway, I'm bypassing my patient's ability to heat and humidify the gases themselves. I want to do my part to try to minimize nosocomial infection. So I'm going to follow my ventilator-associated pneumonia prevention bundles. I'm going to follow my hospital's policies on infection control so that I'm not introducing infection to my patient, infectious particles to my patient. I want to help with secretion removal. provide that appropriate cuff care, as we've talked about in lab and in lecture. We want to maintain cuff pressures inside these tubes to make sure that we're not exceeding the capillary pressures of the tissues around them. Because if my cuff has more pressure in it than the tissue around it, that is going to cut off blood flow and make it difficult for make poor tissue health. As I'm assessing my patient, I'm always looking to troubleshoot airway related problems. Okay. Anytime I have an artificial airway in, I'm increasing my risk for obstruction of that airway, because that artificial airway is smaller than their regular airway. It can become occluded, lose its patency, and then we can lose our ability to ventilate the patient fairly easily. Okay, so one thing we look at is securing the airway. So we're going to be using things like tape, silk, either silk or cloth tape to secure the airway, or using commercial securing devices. Commercial securing devices are usually the recommended route because they cause less skin damage. There's less movement of the tube, less chance of the patient self-extubating or pulling the tube out on their own. Excuse me, sorry. And we want to make sure that when we're securing the devices, we want to make sure that we're always looking to prevent skin breakdown with our ET tube. So whatever device we're picking, we want to make sure that we're using it appropriately so that it doesn't cause skin breakdown and lead to complications for our patient. So here's an example of a patient whose ET tube is taped. Here is an example of one commercial securement device. Here's another example of commercial securement device. So anchor fasts are the ones that I feel like most of our clinical sites and clinical affiliates use. So here's that video on how to put on an anchor fast.
The Anchor Fast Guard Select Oral Endotracheal Tube Fastener provides a convenient means to hold an oroendotracheal, or ET tube, securely in place without the use of adhesive tape. The oral endotracheal tube fastener allows repositioning of the ET tube in either direction along the track without removal of the device. The fastener secures oral endotracheal tubes ranging in size from 5.0 to 9.0 millimeters inner diameter, and endotracheal tubes with integrated subglottic suction lumen sizes 6.0 to 8.0 millimeters inner diameter. The gliding tube shuttle allows the ET tube to be easily repositioned from side to side while the tube remains secure. The integrated tube protection sleeve helps prevent occlusion without interfering with routine care. Using the Anchor Fast Guard Select Oral Endotracheal Tube Fastener. Before applying the device, the patient's skin should be clean, dry, and free of oily residue. Do not use skin gel wipes or other skin preps with the oral endotracheal tube fastener. Remove the product from packaging. Remove the release liners from the two skin barrier pads. Pull back gently on the skin barrier pads so that they are out of the way to prepare for application. Center the device on the patient's upper lip, so the non-absorbent upper lip foam lightly touches the skin. Ensure the ET tube is positioned adjacent to the opening of the tube protection sleeve. Press the two skin barrier pads on the patient's skin and hold in place until they adhere well. This should take approximately 30 seconds. Squeeze the tabs on the sides of the gliding tube shuttle and move the clamp along the track to a location adjacent to the ET tube. Carefully slide the ET tube into the tube protection sleeve. Place the cuff inflation tube within the tube protection sleeve along the bottom and the integrated subglottic suction lumen, if present, within the upper channel of the protection sleeve. Remove the release liner from the ET tube wrap, exposing the adhesive. Before applying the wrap to the ET tube, make sure the ET tube is dry and free of any residue. Position the ET tube under the non-slip grippers. Care should be taken to avoid including the cuff inflation tube and the integrated subglottic suction lumen, if present, within the wrap, and/or directly under the non-slip grippers when securing the ET tube. Loop the wrap tightly around only the ET tube and pull the remaining portion of the wrap through the security clamp. Secure the wrap by snapping shut the one-click security clamp. An audible click will be heard. Secure the neck strap by inserting the narrow end of the strap through the plastic loop on the track. Fasten the narrow end of the strap using the hook and loop closure. For greater comfort and security, adjust the straps on either side. Do not over-tighten. Allow 2 fingers width between the strap and the back of the patient's head. To reposition the ET tube, squeeze the gliding tube shuttle tabs on the outer edges and move in either direction along the track. Reposition the ET tube from side to side at least every 2 hours, or more frequently if the patient's condition dictates, to minimize the risk of injury to the skin, lips, and/or oral cavity from unrelieved pressure and shear forces. Release the security clamp holding the wrap in place. Carefully remove the wrap from around the ET tube. Then remove the tube and inflation lumen and the integrated subglottic suction lumen, if present, from the tube protection sleeve. Release the neck strap by unfastening the hook and loop closures. Remove the skin barrier pads by gently peeling them away from the patient's skin. Anchor Fast Guard Select Oral Endotracheal Tube Fastener. For more information, visit Hollister.
All right. So that's talking about Anchor Fast, which is one of the commercial tube holders out on the market. There's also multiple different ways that you can tape an ET tube. So again, your book talks about silk tape, cloth tape. Silk tape is very, very temporary. It's usually pretty susceptible to kind of getting slimed off with patients' oral secretions. So usually they're not going to recommend using silk tape for long-term securement of an ET tube, but in a bind you can use it to just kind of keep it in place temporarily. Cloth tape is typically a lot better for if you're long-term needing to stabilize the tube with tape. Either way, taping is always not as preferred as a commercial device. So here's an example of just one way to tape an ET tube.
This is a demonstration on taping an endotracheal tube. But for Mr. Dunphy, I've got to put some tube. This is a demonstration tracheal tube. But for Mr. Dunphy, I've got to put some tape around your tube so we can hold it in place. Make sure that you glove up. So I'm going to put my gloves on. This particular device is already prepackaged, which is convenient. I'm going to open this. Okay, once we open it, looks like so. This has a nice glide, so you can slip it underneath the patient's neck. There is the tape portion, the sticky part, and then the non-sticky. So I want to make sure that the sticky is going to be attached to the patient. So I'm going to take, and it tells you this side up. So I'm going to go underneath, I'm going to slide underneath your neck. I'm going to go behind the neck. Then the soft cushion part goes directly behind the neck. So what I do is with my endotracheal tube, I always like to tape the side where the endotracheal tube, the side that it's on. So what I'm going to do now is take off the tape. And then this is already split, so I split it a little further so I can come here. So I'm going to take the top portion, take off this, hold my endotracheal tube, make sure I have the exact place, and I'm supposed to be 24 at the lip. I am. So I'm going to take this, wrapping around my tube. While I'm wrapping, I do not tape my pilot balloon. Okay, I'm going to wrap this. What I'm going to do at the end, and this makes it real convenient when you're taking it off, I'm going to take the end portion and I'm going to flip it over and I'm going to tab it. Okay, so I'm going to take this, wrap it around. Now this part, I'll take a little bit of that off, and I'm gonna go over the top of the lip. Okay, Mr. Dumpy has facial hair, so sometimes we can end up having issues, so I may want to get it a little tighter. And I'm going to pull this tape off. Still take here, and I'm going to take the top. So I'm just putting this somewhere that it's staying out of the way. Take this back over the bridge of the lip. Take this around the tape. And it doesn't hurt. I mean, you can actually cut this so it's not so much wrapped around the endotracheal tube. Once again, take the end, tab it, and then come here. Then I take this and I'm going to pull it over the top to add additional stability. So I take here, come over, and then we have a nice tape job.
All right. So both of those are ways that we typically use to secure ET tubes. Tracheostomy tubes, typically they come with either ties or like a commercial device such as this that's going to go wrap around the patient's neck and then have some way of kind of securing it or velcroing it to the flanges on the tracheostomy. Okay, so those are just examples of different ways that we secure the tubes. Again, when it comes to confirming placement of the ET tube, we're looking to see that the tip is somewhere between 3 and 5 centimeters above the carina. So this chest x-ray that I gave you example here, you can see the shadow of the bronch down the middle. I'm going to get my highlighter out so I can highlight this for you. So you can see kind of the shadow of the trachea down the middle here. Then once I get to about here, I notice the shadow branches off this way. And then again off this way, and that makes my 2 main bronchi. So where these bronchi meet is considered the carina. So I want you typically to see that my tip of my ET tube ends about 3 to 5 centimeters above the carina. So this leaves the tip of the tube right about the 2nd to 3rd tracheal ring, which is good position. Another thing to note when you're looking at chest x-rays, and again, this is something that I encourage you guys to do a lot when you're at your clinicals, get comfortable starting to look at chest x-rays, not just radiology reports, okay? Those radiologist reports are wonderful because they tell you what you're looking at, but you still want to look at the actual film and see if you can start training your eyes to identify things as well. A lot of times now with how fancy and new those radiology equipment is, they're going to do those right at the bedside. You see the ET tube right away or the chest film right away, well before the radiologist ever has a chance to look at it, and you can make your adjustments to your ET tube, or you might even recommend that it gets reshot if there's an issue with how the patient's positioned, because positioning will change the tube position. Positioning of the patient's head and neck does affect tube position. In adults, this usually doesn't matter very much. I can kind of position you whatever way. This is only going to move the end of the tube probably about a centimeter, half centimeter. So an adult doesn't really matter as much. But if and when you guys work in the NICU with the little babies, that half centimeter could mean that you're moving your ET tube a lot. So you want to make sure that there's no flexion of the head. So if the head is flexed downward, so chin to chest, that moves the tube towards the carina. Okay, so if I'm flexed with my chin sitting on my chest, my tube is going to be moved closer to the carina, making it look artificially further in than what it actually is. If my head is extended back, that is going to pull the tube towards the larynx, meaning that the tip of the tube is going to ride higher than what it typically does. So poor positioning of the patient is going to affect the position of your ET tube on the chest film. So you want to make sure your patient is positioned properly. Another way that we can confirm placement is with using bleh. Flexible laryngoscopy or bronchoscopes. That can be inserted down the ET tube and confirm the position of the tube visually. So if you put the scope inside the ET tube, you're going to be able to visualize the carina directly. And by moving the scope from the tip to the carina, you can kind of measure that distance. So you can do this with a bronchoscope as well, but traditionally we do this with a chest x-ray. Okay, so now moving on to talking about patient communication. So one of the biggest frustrating aspects when a patient has some sort of tracheal tube in is that they're not going to be able to talk to us. Okay, so our ability to speak is reliant on air moving through those vocal cords. Okay, so the ET tubes prevent the vocal cords from moving at all because it's going to sit right between the cords, and it's also going to prevent airflow through the cords. A tracheostomy tube allows those cords to move, but because it sits below the vocal cords, no airflow is going to go through those vocal cords. Okay, so typically then we want to provide communication aids to our patients so that they can communicate their needs to us. This is going to help them feel This is going to help them feel better. They're going to have less frustration. It's going to help with delirium and, their sense of reality if they can communicate with us. So I am a horrible lip reader, so I do not rely on my lip reading skills to communicate with my patients. A better solution is using things like letter-based picture boards. This allows patients to simply point to things to communicate. These large drawings are nice because patients don't need to be able to read well or be able to see well in order to pick out kind of what they want to say to us. Some patients may want to use special electronic devices to communicate. So patients that are in more of a chronic long-term setting, they might invest in those electronic devices to help them communicate so they can communicate more complex things. In those types of settings, using speech therapy, though, they can help them kind of pick the best devices to meet their needs. So we also have a couple devices that we put on tracheostomy tubes to help facilitate talking. So one of them is a talking tracheostomy tubes. So this has a separate inlet for compressed gas. So you hook this device to gas flow, and that sends gas flow above the trach through the vocal cords and allows for that phonation. So because it's gas flow going through here, it could cause a air leak around a fresh trach. So not all the gas is going to go this way. Some of it might go around this tracheostomy and cause air leaks. Because it's a lot of airflow, it can cause some drying and irritation of that mucosal lining. And this hole here can get occluded with secretions and not work. But this is one example of something that we may use to help facilitate talking with our patients. Fenestrated trach tubes. So again, this has the holes at the top of it, so air can go down into the trachea, but also air can go up through these holes, pass through the vocal cords, and allows patients to talk. So this particular fenestrated trach is designed to be able to be used with a ventilated patient and with a cuff fully inflated to help the patient communicate while still being vent dependent. Finally, we have something called speaking valves. Speaking valves are a device, usually a one-way device, that is put at kind of the end of the ET tube. that one-way device is allows air to enter into the through the tracheostomy, but then it seals off and doesn't allow exhalation through the tracheostomy, so air goes through the vocal cords.
The Passy-Muir tracheostomy and ventilator swallowing and speaking valves incorporate a unique patented design feature that translates into significant benefits which are exclusive to the biased closed position no-leak design. To understand the principle behind the Passy-Muir patented feature, it is important to first understand how an open position valve operates. An open position valve uses a membrane or diaphragm to perform the valve opening and closing functions. The membrane flexes during inhalation, which allows air to pass around it and through the tracheostomy tube. When the inhalation cycle reaches its peak, the membrane temporarily relaxes and returns to its normal position. At this point, the valve is not actually closed. Reversed airflow, which is produced by exhaling, is necessary to force the membrane against the valve body to produce a seal. Before the membrane actually closes, there is a short time lapse where some exhaled air can escape. In addition, some common breathing patterns create an airflow phenomenon that can cause the membrane to vibrate or oscillate, which prevents it from completely sealing, resulting in noise as air leaks out. The open position valve allows secretions to travel up the tracheostomy tube and potentially occlude the tracheostomy tube in the valve. The Passy-Muir valve has a patented feature that virtually eliminates the possibility of these kinds of problems. This feature creates a closed position, no-leak condition. The membrane's outer perimeter is forced to normally be in a state of compression against a lip inside the valve body. In a relaxed state, the valve is completely sealed, not requiring reversed airflow to close it. When inhalation begins, the membrane easily bends out of the way to allow air passage with minimal resistance. When the inhalation cycle reaches its peak, air stops flowing and the membrane instantly returns to its normal fully sealed position. This is the closed position no-leak feature. As exhalation begins, the valve is already closed, and air immediately follows the path of least resistance up through the trachea and past the vocal folds, exiting through the nasal cavity and mouth. Because the valve closes at peak inhalation, a column of air remains in the tracheostomy tube at all times, creating resistance to secretions entering the tracheostomy tube and the valve.
Okay, so a couple of features again with this is in order for this Passy-Muir valve or speaking valve to work, as I mentioned, air is going to enter through this down into the trachea. And then as we exhale, that one-way valve is going to close and air should pass this way through the vocal folds. So if you're using a cuff trach, that cuff needs to be deflated in order so that the air has somewhere to go. If you leave the cuff inflated, then air is going to get into the trachea and have no way of getting out anywhere because it can't go up past the cuff. It can't go out through the valve here. So you need to make sure if you're using a speaking valve that you fully deflated the cuff. Even with the cuff fully deflated, this tracheostomy tube might be taking up too much room in the trachea and creating an obstruction. So things that you can think about doing to help minimize that is maybe changing out to a smaller size tracheostomy tube, or changing to a cuffless tracheostomy tube, or changing to a tracheostomy tube with that tight to shaft water seal cuff to kind of make the amount of space that this trachea takes up in the airway as minimal as possible. Okay. Okay. So cuff must be deflated. Okay. Eligible patients must be medically stable, able to communicate, have low risk for aspiration. You want to make sure you're keeping the tracheal pressures low. So your tracheal pressure should be below 5. We can monitor that by hooking up a transtracheal pressure monitor to the speaking valve. And as the patient as a patient inhales, that means, or as a patient exhales, if that pressure gets above 5 centimeters of water pressure, that might mean that there's a lot of airway resistance because of that tracheostomy tube. So if that's the case, you want to change out the tracheostomy tube. And again, we'll kind of go through this in a lab when we're talking about trachs, so that it won't feel as confusing as reading it in the book or lecturing about it. But that's kind of the gist of speaking valves when you're using them, especially when this is the first time I'm having a patient using a speaking valve. I'm going to make sure I stay pretty close at hand to make sure that they're comfortable using that upper airway again to facilitate exhalation. So I'm going to be looking at and assessing their patient's heart rate, respiratory rate, SpO2 while they have the speaking valve on. And again, the benefits of using this with patients is to help them with communication, allowing that airflow through the vocal cords, help with vocal cord function. When they have the speaking valve on, there's more airflow going through their upper airway, so they, get a sense of smell back. They're going to have fewer secretions. It's going to help improve their ability to use their upper airway with swallowing and aspiration. So it's just going to kind of be an overall better quality of life for your patients. Okay, so at this point, I'm going to stop because we're at about an hour and I don't want to lecture for longer than an hour here. And then we will pick this lecture back up in a final part 3 with ensuring adequate humidification